For me, for Finland, the biggest problem is that there are things you can measure. You can measure differences between treatment between men and women, for example.
Mm-hmm.
But it is not allowed in Finland to, and I wouldn't like to have in electronic patient records information about ethnicity or who is rich and who is poor. It is not even allowed. So at practice level, there are things we won't be able to measure. It is okay to do research and believe that it is the same situation in each practice. But this is much more difficult to measure at practice level than any other thing. And I don't think that we should use too much effort in measuring, because we can do a lot of things even when we don't know exactly how it is. Because there is some research even from different countries. So I wouldn't put effort in measurement, I would put effort in action in this matter, because it is so difficult to measure. And even sometimes unethical to try to measure it.
Can you give some example of action?
This is from another field. There was a discussion, Green Party had a discussion about these matters in healthcare, social healthcare. There are examples from, for example, education, and teaching groups are smaller in certain areas, so we could have shorter lists for doctors working in certain areas. So kind of, instead of giving them more money, which is not helping so much, we organize their work that it is a little bit easier because it is more demanding. So things like that we could at least try, learn from other fields such as education.
But I don't know if I totally agree with what you say, that it's unnecessary and even unethical to measure.
It is okay to do research, but for example, to in electronic patient records to have information about ethnicity. It's not allowed in Finland.
It's not allowed in the Netherlands.
You're not allowed
Because
to
you are
have
labeling people. Not religion, not ethnicity, not how much you are earning. It is not allowed.
And did the patient agree?
No, it is in our laws, things like that are, it is called, I can't translate it, but it is information which is protected better than other information. So there is a law which is saying that you shouldn't have personal information which is protected.
Also not as a doctor.
Even not in the medical.
Well, if ethnicity has something to do with your treating this particular individual, then it is okay. For example, sickle cell anemia.
Mm-hmm.
But religion or ethnicity, otherwise it doesn't kind of affect.
So, but that departs from the idea that you should give everyone the same care. And
Yes,
then
yes,
you're
but
equal.
I'm saying
The doctors know, but
The
it's not.
doctors know.
Yes, but I'm saying, and at the moment in my country, we can't measure this because of our present legislation. You can say that it is not correct, but that is the situation.
So you may register it in the clinical medical record, but you may not extract the data. Is that the point?
That's the case.
Okay.
Yes, but
It's not
what I take out of this discussion is that there is a very important ethical part in it, and that we should also put it on the agenda. What are the things we need to identify vulnerable groups and to make less inequity? And is privacy so absolute that perhaps this endangers exactly this strategy?
But
That's
there
a balance.
are
That's also
data on
balance.
national level, that's not a problem.
Yes, but not on practice level.
Yeah. Yeah, that's exactly my problem. On national level you have the data, but on the practice level where you need it for measuring or for doing, well, if you can't measure, you have some problem.
Lisa,
I think
you-
you
I don't
you
think
can
it's a problem at all. I'm working in a very deprived area with a lot of ethnic minorities who do not speak it. I have it in my head, and that's for that concept I have to use it. If you want to describe my practice population, I can get data from the register at the national level. I do not need to measure because people's income have not, for the single person anything to do with how that single person manages her problem. So it's not enough. You cannot use these indicators alone because it's about the relation and the power, empowerment of the patient, help themselves. That's important to say.
And how can you translate that kind of personal knowledge to another doctor who replaces you?
Then they do not have to have that. I'm talking about the relation. Because when we talk about deprivation and socioeconomic deprived, we have their results on group basis. It's not all persons in the group.
Do you mean that the quality of the patient-doctor relationship can fit you with the different groups of patients, or the different, that can fit you with the patient, and as a consequence that equity is guaranteed?
I can see you can need them for research purpose and document them, but I cannot see you have to use them in the context in your own practice.
You don't have to have all that information in order to make an action. You can act even in a situation
No,
you don't know anything.
but don't you need that information to see whether you have a problem in your practice that you have to tackle? How do you know do you provide equitable care?
I can see at the outcome level to see how is the blood pressure.
You don't know because you don't know the social status of your patients.
But then the answer is that I can't do anything because I can't measure. And that is not the case.
But I think if you make a simple quality improvement initiative going for people, that children that should have their immunization, women that should have their pap smear, yearly control or half-yearly control by diabetes and apoplexy and all these things. What we have done in our practice, and that was made in PhD about the children in Denmark, among these people not coming, there'll be a very high rate of people that are coming from deprived areas.
Mm-hmm.
Then we don't ask them to come because they are deprived. We are asking them to come because we have a plan and they do not come, and then they accept it.
Mm-hmm.
And we can, from a scientific point of view, find out. Now we work more with these people as they should have an extra letter. So we are, but we are not asking them to come as we have registered them as problem patients.
No.
But they are just not following
Not
the
vaccination, and that was enough.
so and that is reasonable and that's accepted by the patients. So that's so just do a proactive. That is proactive in real life, and we don't work proactive in Denmark. I don't know if you do in Belgium and Finland and these places, but if you do that, you will start to tackle the deprived problem.
Yes, so your point is use a functional level and not a formal level? So
What I understand is don't label patients.
Yes.
But look
Like
into
the lady we saw
problems.
here, don't let them leave.
Yes.
Write and ask them to come, and they will come, and they accept that they will
yes,
come.
so 20% is not coming for vaccination.
Yeah.
You have that kind of information. That's enough to go in.
Well,
Yes,
you
yes.
go into this 20% and you analyze and you go on with this 20%, independently of what is their origin, as their name, as their gender.
Because
And you
otherwise
don't-
you have the risk of stigmatizing.
Exactly. If you don't stigmatize, and you should have your immunization, or perhaps and all these things, and just start with that simple thing. Then it's a
It's because of medical reason we contact you.
Yes, but you can use in your analysis this kind of things to see what is the reasons why you are yes or not attending. And then you can build on your strategy. But then you don't need this in the medical file. You will see it when you see it coming up the names in your list. To see what strategy you
Two
use.
remarks of Luc and of Robert, and then we stop because we have to make conclusions.
I want to switch to another level because I believe that there are multiple approaches possible. So I will give you an example of what happens in our region. So I told you we are a rather rich region with not so many deprived persons, you think. I don't know exactly, but the community cares for these people. They know who these people are because they get a lot of services by community support. And so the community knows who these people are, and well, we have a prevention program in our region on stop smoke cessation And one of the initiatives was to go to this community, to go to this group who gathers by breakfasts every week once, and the doctor, the GP, who's a tobacologist, proposed there a series of free program for stop smoking, and they stepped in because they were a group of peers, and they worked together to stop smoking, and from this program they came into my practice, and they said, well, I really want to stop smoking now. So there's also another level in which can be used to start up.
So thinking as a practice that you're working in the community and looking into the community needs and tackling this community needs may be another way of reaching those people.
Yeah.
Okay, I think it's 3:10. So if you have the final word, yes, I give it to you.
Okay, that was just a very, very practical way. As Lars told, this children not showing up for immunization. In our practice, we have a nurse dedicated to follow up on them. And with the knowledge we have in the practice about the patients, she uses different approaches to these patients. And it isn't registered with small tick boxes, but we know these patients. Some have an email, some have a phone call, some have a letter, some have an SMS, and some have 2 or 3, and so we know how. Yes.
So being diverse, I think that's very important if you want to tackle importance. Change your strategy according to the needs that you want to reach.
And the success rate is over 99.
Yeah, but in that case and in our practice, I can see the importance of the contact of the practice assistants with these patients. They know the patients, they go through the village, they say goodbye and so on. So they have a lot of background information which we even don't know. So they have another kind of contact which is also very important to foster this low pressure.
I will close down the official workshop, sorry. But I think it will be unofficial afterwards, but then people are free to go for coffee or for the next one. I thank you for coming to our workshop. And for me, it's in the 2 directions, that we give some information and some questions, but I received a lot of information from you as well.